lesion. What aspect of the arm does the radial nerve control? The extensors. Exactly. So they are responsible for working this aspect of the arm, right? So in a complete radial nerve lesion, your patient will be presenting with what is referred to as wrist drop. And when you see somebody who's presenting in wrist drop, they are very much stuck in this position. There is almost no tonicity happening in the upper portion of the arm here, and the flexors are literally contractured, so they are kept in this position here. Okay, so that's the presentation we are going to be working with today, but because of the fact you guys will have lots of time to practice, we're also going to incorporate an element of treating just the upper half of the body as well too. Okay, so for this patient in particular, if they were presenting with wrist drop, odds are I probably, depending on how significant it is, I might or might not work on treating the upper portion, back, neck, and shoulders first to get a reset there. I might just hone in on everything here, but for the purposes of demonstrating also just an upper half treatment, we will be starting with Ryan face down on the table just so we can give general treatment of the upper portion. But again, in practice, I probably would spend the majority of the time on this patient face up into the chest, pec, shoulders, upper back, and down into the affected arm. And then a little bit of care on the opposite side because that's principal treatment, right? All right, so Ryan, thank you for joining us today. There we go. There's his presentation. So we're going to be addressing his postural presentation, as well as the fact that he is presenting with a radial nerve lesion, which is wrist drop as his presentation. Okay, all right, so Ryan, we are going to be addressing issues related to your arm here, including trying to encourage strengthening of your extensors. We're going to try and decrease the tightness happening in your flexors here, as well as see if we can address some of these postural issues that you're experiencing here. So what we're going to do is we're going to provide treatment for you on the upper half of your body, including your back, your shoulders, probably into your neck a little bit, as well as down into your chest, arm, and all the way down to your hand. The purpose of this treatment, I've already told you what we are going to try and accomplish, and the positives is hopefully we'll be able to decrease the severity of your symptoms, but there's a chance you might notice some discomfort during treatment or after treatment. If you do experience any discomfort, please let me know during treatment and I will modify accordingly. If you do experience any discomfort after treatment, just know that it will be temporary and it is also very normal as well too. What I'd like you to do is I'm going to go wash my hands. I'll get you to please undress yourself in the upper half of the body and then lay underneath this top layer here with your face resting on the cushion and between these two layers. Okay. Any questions about all of that? No. Do you have your permission to continue?
Yes. Can we say my left side is my affected side?
Sure.
It's actually like that.
Okay, yeah, sure, yeah.
So I have weak.
Sure, let's do that. Left side's affected side. Oh yeah, also y'all be careful getting onto these tables knee first. We've had a student actually break the table because he put his knee directly on the edge and it just went kapoof. Wow. So if you can, try and avoid getting your knee, like getting on with a knee dive. All right, Ryan, would you like me to go through the pain scale?
No, that's okay.
I appreciate it.
I've heard it before.
Once or twice. Once or twice, right? Okay, so first things first, before I go into treating anybody's specific issue, I usually do a general reset of the upper body. So I will actually pre-note this because I know we're going to be doing lots of demos going on. I will not be giving you guys a step A, B, C, and D. We're going to discuss what the goals are that we're trying to accomplish and the different methods in which you can use to get there. You will notice that my approach is actually very, very different. So do not take my approach of what you see me demo as like, it has to be done this way. This is just an example of how we can reach those goals. All right, so if you have questions about anything that I'm doing, be sure to let me know. But generally, you are going to be utilizing the tools of what you've already learned. You're going to be using your Swedish techniques, petrissage, some therapeutic exercise. So just keep in mind that I will not generally be treating the way that y'all have been shown in class. Okay? I keep forgetting to tell people that. All right, and actually I do. Does anybody have a set of folded linens that are both folded the same way? All y'all keep your linens unfolded? Okay. Does somebody have a pair of linens that I could just borrow for a moment, please, that can be folded the same way? I didn't think you needed them, but you do. Sure, yeah, and then do you have another one folded the same way? See, nicely folded, very good. And out. Keep going, keep going. So this is literally just me setting up for treatment. I can make my own sound effects over there, okay? All right, so just by doing that, just by bringing his shoulders back, all of a sudden the tissue in his back is willing to move. When at first, with his shoulders dropping forward, because of that tension that was being applied on the posterior chain, it was strapped tight and the tissues were not nearly as willing to move, right? So I don't actually have to do as much work in his upper portion as I thought. He needs it a little bit. You said left side's your affected side? Okay. So we'll actually treat his affected side. Good, so you guys will see me utilize a lot of the fascial change throughout my treatment. And now take a big breath in and out. Good, drop your side. Good. And again, breath. And out. Good, let that drop. Good. So I actually don't need to spend too much time with him face down. That's great. Have you been getting treatment?
Trying to.
Okay, good. Good, nice big breath in. And out. Good, let that drift upwards. Good. And again, breath. And out. Good, drop your stomach. There you go, good job. Good. Actually, yeah, that responded super easy. Yay. So normally I just spend a bit of time with them face down, just trying to get things even out a little bit. I could spend a little bit more in the lower portion of his low back where it meets the hips, because he needs it, but for the purposes of what we're trying to accomplish today, we're focusing on the upper. So for turning somebody over, for the purposes of your exams, please remove all of the pillows, including the shoulder pillows. I don't personally when I'm dealing with things like hyperkyphosis, all that stuff, just because as soon as we remove the shoulder pillows, right back, all our hard work is done, right? So for the purposes of when you're being examined, somebody's in a clipboard assessing your skills, please remove the pillows, okay? Cool. And a little note for when you're actually having somebody turn over, one, note where your examiner is and try and stand in front of your examiner so that they don't get a view of anything. When you go ahead and get your patient to turn over, a couple things. I've seen this in an OP when you have multiple individuals being examined. I have had somebody lift just the top layer and told them to turn around. There's other people in the room. And there's also windows, all that jazz. So if you can, try and cover it. Personally, as a patient, I hate it when my therapist does that because it's cold. All right, so what I like to do is I actually lift both halves, and instead of just leaving it like that, because there's a little bit of a gap there, you can actually fold the layers over themselves, create a lovely little lip. Do your patient a favor and look towards their feet the entire time that they are going through the motions. And then Ryan, I've secured everything. Can I get you to please move down on the table and then turn over onto your back, please? Because that way, lifting up the bottom layer a little bit, you're actually giving them a little bit more room rather than planting them down. Right? A little bit of space so they don't feel like they're in as tight a burrito. You okay, Muffin?
Good.
Cool. Thank you. Okay, now, disuse atrophy. That's a bigger pillow. Oh, but that's the fabric pillow. Gross.
Should use pillowcase.
got the left side as your affected side, right? That side, okay. Can I get you to go ahead and bring this arm outside for us? And actually, you know, we'll do both sides. So usually I would get my patients to place their hands on top of their stomach. It's not a mandatory thing, but especially since the majority of individuals who we treat are going to be presenting with shoulders forward. Try this with your patient when you're doing your exchange. Have their hands start on their stomach, place your hand on their GH joint, and see what happens when you actually put their hand down. You will feel their shoulder come forward. Right? So when you actually put their hand on their stomach, it allows that shoulder to fall back in that neutral position. Thank you.
Can you grab that for me, please?
Thank you. Good. Okay. So with an individual that's experiencing a wrist drop presentation, we'll say it was a radial nerve lesion below the elbow, so he can still use his elbow. Good, so he's a little bit contractured. One thing we want to consider, if you guys are dealing with true atrophy, you are going to want to position their limb in a way that the limb is supported. So in true atrophy, in the case of a radial nerve lesion, if they're experiencing true wrist drop, we would actually want to place their limb supported on the pillow. Okay? So we'll just do that one for now. Somebody who's experiencing this presentation, and was it forward when you had after your surgery?
Yeah, it was.
It was along the posterior chain?
Yeah.
Okay, cool. So I don't know how much you guys know about Ryan's hand injury, but he broke his hand, and he actually was experiencing a bunch of atrophy throughout his arm, his forearm, into his arm, and into his chest and shoulder. In fact, there's still, you can tell between the two that there is still a decrease in muscle tonicity. So actually, before he gets off the table, is it all right with you if like they do a palpation?
For sure.
Okay, cool.
Sure.
So after we do our demo today, I'm gonna get you guys to come over and actually assess the difference in quality of the tissues in his pecs, feel down into his biceps a little bit, and then let's actually see if we notice, yeah, and into especially the both actually, flexors and extensors. Okay, so see if you notice a difference.
You could see it like into my
Into the hands
I think
as
it
well,
came
too.
a little bit back, but yeah, before you could see it in the hands as well.
Mm-hmm.
So.
Yeah, no, so he's mostly recovered, which is great, but he's still experiencing some deficit. Okay, so somebody has a drop wrist presentation, or they have a contracture along in their flexors, a decreased tonicity happening along in their extensors. What else do we expect to be happening higher up into the chain? We don't know. Okay. Compensatory pattern changes. So with that, as I mentioned, with his injury that happened in his hand, he was experiencing changes all the way up the chain. So keep in mind, just because somebody's experiencing their primary issue super far down the chain, you need to explore to see what's happening up the chain for the rest of it. How much were you experiencing your neck and everything?
Neck was over. My neck was fine actually.
Yeah, it feels actually quite tight up here. So if anything, maybe just guarding and holding close to the body. Okay, so with this presentation, would I just go right into trying to address everything locally to where he's experiencing the most problems? No. No, what would I try and do first? Principles of massage, exactly. A nice big brush. And out. Good. So literally all I'm going to focus on is making sure that the tension throughout the chain on the front versus the back feels the same. All right. Good. Take a nice big breath in and out. Good. And he is a great body because he's had lots of practice being able to actually fully relax. He still has his restraint. Good. Can you hit my handle for me, please? Thank you. Good. So normally at this point, if he didn't have his wrist drop presentation, I would encourage the person to let their wrist fall backwards, but he has wrist drop right now, so I can't do that. Good. He still needs work into his pecs though. So I usually don't go straight into the pecs when I work there because a lot of people do a lot of bracing. So I usually treat the pecs indirectly. Okay, Ryan, big breath in and out. Good, and nice and gently, I'll get you to try and pull your elbow across your body to your opposite hip. Go ahead and pull. 5, 4, 3, 2, 1. Let go, breath in and out. And you can go ahead and drop your hand and pretend it, yeah. Good, and again, try and pull your elbow across your body. Hold for 5, 4, 3, 2, 1. Let go. What technique am I applying? PNF. Good, okay, so now I've done some proximal work and now I'm gonna move into where it's actually experiencing his dysfunction. So I could go right into trying to stimulate things right away, but honestly, I would probably go in and try and let go of some of the contractured tissues first. So he's gonna be in this presentation, gotta make sure we support it properly. I'm gonna push my lever again, please. Thank you. All right, so from here, some of the things that we can do to encourage elongating these tissues, combination of just passive prolonged stretch, but we can utilize PNF here as well too. Okay, Ryan, I'll get you to go ahead and gently try and bend your elbow for me. Hold for 5, 4, 3, 2, 1, let go. And the thing is, with him being in a, let's say it was a true atrophy, he had a radial nerve lesion and he's in full wrist flexion and we can't get him to activate that, that's when we can recruit the fact that a lot of those muscles cross the second joint line and we can utilize elbow flexion as well too. Good, and gentle, go ahead and contract in there, good, 5, 4, 3, 2, 1, let go, breath in, and out. So keep in mind, PNF stretching, there has to be that elongation of the tissues after they let go. There has to be a lengthening of the tissues after it's contracted. Okay, in the case of disuse atrophy, he will probably still be able to use his wrist, right? With permission, Ryan, can I rest your wrist on top of my?
Yes.
Thank you. So here, once we've utilized the elbow to exhaustion, because he can still actually activate these muscles, then we can actually get him to recruit those. So, Ryan, I'll get you to go ahead and first what's going to happen is I'm going to place my hand interlocked with your fingertips here. When I say so, I'm going to get you to try and curl your hand and curl your wrist, and I'm going to try and pull you out of it, but don't let me do that for 5 seconds, okay? All right, ready? And go ahead and hold for 5, 4, 3, 2, 1. Let go, breath in and out. So this is if he doesn't have like a full contracture, because if he had a contracture, would not be able to get this far, right? But you can see what we're trying to accomplish here. We're trying to lengthen those tissues that are not fully lengthened because they're working too hard. Anybody confused by that aspect? Cool. And again, go ahead, try and close fist and hold for 5, 4, 3, 2, 1, let go. So one of the biggest mistakes I see with this specific technique is a lot of students will not go to the end range of restriction before they activate. Okay, so somebody will want to PNF stretch the biceps, and what they'll do is they'll just go mid-range and say, okay, hold here, and then they don't actually challenge the end range of the tissue. The goal is you want to approach the barrier where the tissue starts actually resisting your applied technique. Once you're in that area, you can actually see how, even though he's not at full elbow extension, how the tissue is it's holding. It's not fully letting go. So that is the tissue restrictive barrier. So this is where I'm going to go ahead and get him to apply that elbow flexion. Okay, Ryan, go ahead and gentle hold for 5, 4, 3, 2, 1. Let go when he breathes in and out. The tissues will further elongate to allow us to bring the tissue beyond the last restriction. Do we remember the name, or have you encountered yet the name of that physiological response utilizing PNF? You said it even quieter. What did you say? The response is called reciprocal inhibition. Do y'all remember that phrase? Okay, so there's two principles for that. Reciprocal inhibition is one of two things. It's the reflexive lengthening of tissues after a contraction. So reciprocal inhibition happens in two aspects. When the biceps is contracting, it is through reciprocal inhibition that the tissues of the tricep will lengthen in response to allow the bicep to elongate those tissues to perform the motion. Correct? All right, the second form of reciprocal inhibition is when we go ahead and we contract that bicep maximally or submaximally for an extended period of time to load through the tissues. When they let go ahead, Ryan, you can contract for 5, 4, 3, 2, 1, let go. There's a reflexive further lengthening of those tissues that has just contracted. So that's the other type of reciprocal inhibition, and that's the reason why we want to go to the end range of restriction, get them to activate into that range a little bit, and then you'll be able to actually go further in that tissue range. Okay, so those are the principles that we're utilizing, but keep in mind the purpose of PNF is to apply the stretch to the tissues after the contraction. A lot of students forget the stretch afterwards. It's PNF stretching, not just PNF, it's PNF stretching. All right? All right, so we've lengthened all to beat heck these forearm flexors. We're able to get a little bit more extension of the wrist. All right, we've gotten these structures to let go a little bit. What's the other half of the equation when it comes to getting the muscles involved? That's it, we're done?
Flexors.
Yeah, that was the flexors. We just worked on lengthening them, getting them to elongate and let go and not be so stuck and held in place. Now what?
Extensors.
Extensors, what about them?
Stimulate.
We need to stimulate them. We need to get them firing. So what are some ways we know how to do that? Muscle activation. Yeah, so there's a variety of ways that we can do it. So if they are super, super weak, what is our first go-to? AROM, right? If they're able to do AROM, it's like, yeah, I can do the things, still not very strong. So what's the next step of encouraging the use of those muscles? Break test, which is what type of contraction? Isometrics, exactly. So you want to be very, very careful about not applying too much pressure, and that's why we don't want them to do concentric, eccentric contractions, because through our muscle testing, we know that that is more intense than a break test, right? So that's why we go break test first. So, Ryan, what's going to happen is I'm going to get and gently bring you into this position here. Open your hand wide. Okay, I'm gonna try and close your hand and push your wrist downwards. I would like you to resist that motion for me, okay? Ready? And 5, 4, 3, 2, 1, relax. Good. And then when you guys get into neuro treatment, you'll be able to utilize some stimulating techniques. Have you guys done sports massage yet? Next term? God damn it. Okay.
What about roots? Do I do roots?
That's,
Yeah, next
no,
term?
that's term 5.
Oh, okay.
Yeah. So what are some, what can you think of as being a stimulating technique? You guys know all your inhibiting massage techniques. What are some things that you can do to help encourage awakening the tissues? Tapotement, exactly. So you can do various like pansement, wake up, wake up, wake up. You need those tissues to start doing their job, right? You can do, just hold your hand here. You can do some jostling, exactly. Right, try and get those exactly vibrations. So utilize your stimulating techniques combined with what? Good try. Swedish, absolutely, to blend them all together, but specifically, you're trying to wake up those tissues. Hey, wakey, wakey, time to wake up, and getting them to move. So what's gonna happen, Ryan, is I'm gonna go ahead and try and jostle this tissue awake. And as I'm doing that, can I get you to go ahead and just open your hand and try and pull your wrist back for me? Good, and relax, good. And go ahead and pull and let go. What if they are unable to actually complete the action themselves? You can assist them. So if he's trying real hard, but in the case of if the neurological system is involved and he's not quite able to make the action happen, well, guess what? You can try and waken up those tissues to get him to try and activate. You're gonna show the tissues what motion we're trying to accomplish, and you can tell him to imagine he's doing it himself. So try and establish that mind-body connection, right? So in order, it would be AROM, then it would be assisted AROM with some sort of awakening techniques, and then isometrics. We jump to isometrics after, because this is still technically AROM, right? So there's AROM, there is assisted AROM with Tapotement's techniques, there is our isometric holds. What comes after isometrics once they're starting to gain a little bit more strength? concentric contractions, exactly. So you can actually give a gentle resistance. Okay, Ryan, what's gonna happen is I'm going to go ahead and try and keep your hand shut gently, and I'm gonna get you to try and open your hand and pull your wrist backwards, and I'm gonna let you win this movement, okay? Go ahead and open and pull backwards. Good, 2, 1, relax. Good, we're gonna go back down. We're gonna do that again. Go ahead and open, 5, 4, 3, 2, 1. Good job. We're gonna do that one more time. Ready, and go ahead. And 5, 4, 3, 2, 1. Let go. Good job. So one thing you'll learn as you go along in the program is that when it comes to stimulating techniques, the key is repetition. So you want to continue to do it as many times as possible. So once you've gone and done some stimulating, you can do more stretching on the opposite side, trying to get those tissues to lengthen while he's activating it, actually. So we can do a little bit of a fascial release, and then Ryan, I'll get you to open your hand, pull back, good, and relax, good. And I'm gonna get you to open your hand and pull back. As he's doing that, he's actually stretching the fascia of the anterior chain, and I am further shearing it. All right, so it'll be a little bit uncomfortable. Good, and then relax. Good job. And then we can go back to trying to stimulate again. Right, wakey, 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 wakey. Good job. So generally the goal is to start with AROM, do AROM with supportment, do some isometrics, and then go through to concentric. If they're able to perform the concentric contraction, no problem, no pain, then you can go into eccentrics. But keep in mind, this is when they're already mostly recovered. Eccentrics will look like this. Okay, Ryan, so what's gonna happen is now I'm gonna get you to go ahead, pull your wrist back and open your hand. I'm gonna go ahead and try and close your hand and bring your wrist downwards, and I would like you to resist, but I would like you to still let me win. All right, ready, and 5, 4, 3, 2, 1. If you really want to be tricky, Ryan, I'll get you to go ahead and now try and win against me. 5, 4, 3, 2, 1. Good. Now resist me. I'm gonna win. Okay, ready? And 5, 4, 3, 2, 1. And again, go ahead. You're gonna win. 5, 4, 3, 2, 1. Good job. Very good. Now, with this condition in particular, we know that the flexors and extensors, there are some of them that actually cross this joint line. So if by chance they are unable to do motions of the wrist, as I mentioned, you can start to actually recruit motions of the elbow, right? The flexors will help assist with elbow flexion. The extensors will help assist with elbow extension, minimally. All right, so utilize those if you can. After you've done some stimulating, some inhibiting techniques on the flexors and extensors, is that it? I'm just gonna end treatment right there. What else am I gonna do?
Flash out.
Flash out. Flash it out. Yes. Exactly. All your Swedish techniques, you can go back. You can probably end off with some neck and shoulder stuff. In fact, I highly suggest it, because after doing all of this, considering we're making them do work, odds are they're gonna tighten up a little bit during that treatment because they're actually working. All right, so I'd finish off working on this side here. Of course, we know I started treatment with his unaffected side, as we're always supposed to, but you guys saw that in your minds. Any questions about performing specific techniques? It seems really simple when you think about it, because it actually is. Any questions?
When you start, did you do it for scapula or did you do it for back?
For what you saw me doing?
Yeah.
I did both. So when I had both my hands underneath, I was targeting into the scap, and I was trying to actually do like a lateral shearing of the scapula. But then when you saw me actually grab onto the top and get him to contract across his body, that was targeting the pecs. Yeah, good question. And then I would go in, deal with the compensatory stuff, go into the neck and shoulders, make sure they're feeling okay, maybe touch base on the other side a little bit if he feels a little bit achy there. Other than that, any questions about all that? Okay, so nice and briefly, what we're gonna do is we are going to quickly